Yeah. Okay. So it's okay with you that we're recording.
Yes, it definitely is.
So my thinking about this recording is we're making it for one of my classes in the leadership course. But if it's all right with you, and you get to decide at the end, not at the beginning, but if it's all right with you to show it anywhere else, I'd love to be sure that that's okay. And you certainly will have a link to it and can use it in whatever way you want.
Perfect. No, I love that idea. And I love the idea of like sharing it as what we can and make it even a PCBH corner. I love that. I think that's a great idea.
So the class that we're working for here, it's coming up, is called, or I'm calling it, Making Data Tell a Story. And I thought of you because you have almost uniquely in the field been willing to share data and to use data as a beginning of a conversation in the way many others don't. So when you, and I don't know, it was a few years ago that you started putting the sort of monthly numbers or the quarterly numbers from your program on the listservs on CFHA, I guess. And you invited people to talk to you about it. You shared what's the data points that you keep. It was very clear that if you're sharing it with us, you've already discussed it in-house, and it's already been the focus of a conversation about in a number of areas. So I love the idea of thinking about what you're going to do with the data and what story you want to tell and who you want to tell it to. So I know you want to tell it to yourself and the people about whom the data is kept. They definitely need to have access to it and regularly. But then again, there's your colleagues in the work, the medical colleagues for sure, the administrators, both financial and programmatic, and clearly your colleagues generally in the field, maybe other administrators outside your organization, I don't know, and to some degree, perhaps with patients. And so I just wanted to help to get your thoughts on how do you determine what to keep? Are there ways that you can use data that other people collect as part of their care to tell your story? If behavioral health is integrated into things, you would think that data about diabetics or various other groups that the medical folks want to keep will in fact speak to your work. And I'd also, and I probably should share these one at a time, but is if there is data that you keep but don't share or don't share regularly.
Yeah.
So, I know Neftali talks about keeping all the productivity data in his clinic and but not running it back at people, that people could see it if they wanted, but that the message was it's about care, not about your productivity, and that the productivity tends to evolve more and more efficient over time. That is his story. So maybe you start sort of telling us about how you think about it and how you use it, and then I'll ask you questions when I think of one.
Please. Yeah. And I appreciate the opportunity to be able to do it, because I love talking about data. It's interesting. My mind always goes to the first thing, like what started us to do this. And I think really what started us to start really tracking our data and then also starting to share it was a couple different kind of confluence kind of events that were happening simultaneously. The one is this, like, whenever we go present and whenever we go to consult, would hear some really like crazy stuff as far as like data about how many patients people were seeing, like from both ends of the spectrum. Like I would hear from some people like, oh, I'm averaging like 20 patients a day. I'm like, good God, that's incredible. And then on the other side of people just being like, oh man, like our system, across the system, we're averaging like, we think we see like 3 patients a day. And then I remember going to some presentations as well, as far as like what number of handoffs there's supposed to be and all this different stuff. So I think there was a part, and then also this question, I remember talking to, Jeff and Patty and Kirk about this during Bridget's and my intern and fellowship years and then beyond, of like, are people actually doing PCBH? Like, are people actually doing it the way that it's like discussed, that it's talked about, as far as the high volume, the number of handoffs, the variety of different referring problems that people are having? And there was always that question of like, because I'm not going to lie, like there was a lot of times I was talking to people and it's like, clearly no one was, or there wasn't a lot of people that were having these numbers to really back that up. So that was happening, and we were getting really curious about it. And then simultaneously, and you kind of said this, we were looking at it as a program of really trying to use data, one, to show if we were doing what we were saying we were doing, that we were actually moving towards these things. And then second, really trying to break down that relational frame that data is bad. That data has to be used in a punitive measure of almost like saying, hey, look at this data, no one's doing what we're saying we're doing. And almost like the exact opposite way of saying like, hey, these are our values, and these data points are actually really reflective of our values. Like, it's a really good quantitative way of actually saying we are meeting our values of serving our community, being their providers and whatnot. So those things were happening simultaneously. And then we just, fortunately, we have a great analytic team that was really motivated and passionate about trying to develop reports. And so that's, I think, what really started us on our journey.
Tell me a little bit more about their analytic team.
Yeah.
Other people who may not have one may not have any idea what that is like, or what they do.
Yeah, my mind always goes, there's people in our organizations that we don't talk about a lot that we should probably become best friends with. I mean, clearly we always talk about PCPs and MAs and support staff. We very rarely talk about like our EHR people, our analytic team. So anybody that's pulling data, and a lot of people, if they're working for a health center, there's someone in your organization that's pulling data to report out to insurance companies, to report out to maybe quality-based metrics or quality-based insurance contracts that they have to show data for. There's probably someone in your organization that is doing that work. We just never talk about them. We never talk about like their value and what, who those individuals and how meaningful they are. So what happened for us was 2 things happened. One was our EHR team was saying, hey, we're really trying to develop templates for departments. We really want to build up our templates to standardize different things. And then it also led into simultaneously the analytic team saying, hey, when we develop templates, we can now easily pull your data. Basically, the idea is, and Sandy, you know this better than anybody, if you don't have a checkbox in an EHR, so you can't track that data. Like if it's a word that, if you're narrative, and I'm for people, and I have a lot of grace and compassion for people that hate checkboxes, because I know you can get checkbox fatigue. The reality is though, if it's not a discrete field, something you're pulling in, or if it's checkboxed, it ain't getting tracked. It's going to be very, very difficult to get tracked. So that's where our analytic team came in and said, hey, you all are talking about developing a template. Are there specific data points that you want to be? And we were like, please, because only thing we're doing is just we're hand counting anything. And we literally would hand count handoffs. We would hand count our visits per clinic. And it was terrible. It was such a waste of time. It was needed, but it was such a waste of time for us to do. So those analytic people that I really didn't know existed in our organization, we started having regular meetings with them, and they were very responsive. And what was really cool about it, Sandy, I will say, it is amazing about just how human behavior is like, there's fundamentals about human behavior. The more we told them how helpful it was, the more positive feedback we gave them, the more gratitude, kudos, and thank you. Their engagement with us went through the roof. So now it's like what used to be like, it would maybe take a week or 2, maybe even longer than that, to get a response back from my analytic team. I can literally send an email today and be like, hey, I think our report isn't pulling the right way. Can you look into this? It's within an hour. They're sending it back saying, hey, we're looking at this. Yeah, this is where it is. In my mind, who knows? My mind predicts, though, it's because of us really making sure that we're like, you all are providing such an important story for us. You're providing such an important metrics and data points to us, like our gratitude for it, that has really allowed them to kind of lean back into us and be like, hey, we're going to help you with these reports.
Mm-hmm.
But yeah, and I think the other thing that's come up with the data is like, what do you track? Right.
Yeah.
And,
everybody wants to know.
Yeah. And so,
and they often, they want to know, how do I get the absolute truths? How do I, if I'm going to know how many people have anxiety, how come I don't have to give everybody an anxiety screen, or that we need to add a data point for every new thing we want to know, and that's a struggle.
We were talking about this. Yeah, we were talking about this with our Bridget and I don't know if we were doing a presentation or a discussion point, but we were talking about this. And so Bridget's dad, so I think everybody's going to know who Bridget is on this, but Bridget Beachy is our director of behavioral health. And she, her dad was a district manager for Home Depot, and particularly right after the 2008 financial crisis kind of happened, and obviously companies were in really tough shape, particularly people like Home Depot that obviously do a lot of home improvements and different things. That was really a tough time for them. They got a new CEO, and basically what that guy said is like, we're getting back to the basics right now. And the only data metrics that we're interested in is we're going to keep it simple, keep it simple, stupid, that KISS method. Like, we are only focusing in on what is primary importance for us. Because to your point, Sandy, I mean, we could pull data about everything. And, I don't think that's a bad thing. I think that could be a potentially really great thing. But the more data points you pull out, the more like the values start to get dispersed. It's more like, well, what is really important? What are those metrics that no matter what, yeah, we're going to pull some different things and maybe some different outcome measures and stuff, but what are the primary things that you want to make sure? And for us, it really drilled down to, and I'll try to go through, I think because there's 5, we always talk about it. Let me see if we can get the 5. One is just number of visits that a BHC is seeing. And we do this for a number of different reasons. One is when we talk about BHCs in primary care, and this is something we talk about with our team regularly, the reality is that, an adult in the United States, 8% of the adult population will see a mental health provider in a given year, according to SAMHSA's data points when they point out. I'll be real with you, that doesn't sound right. Like, I don't know what right is, but that 8%, that doesn't sound right, right, in any way, shape, or form, right? So when we talk about productivity, and every month, everybody gets their productivity. Every month, we have an award show that we do, and everybody's productivity gets put on the screen. Now, we do specific things. I'm making it a fun process, and we're reinforcing positive behavior and definitely the behavioral principles, but everybody's data goes up there. And the thing that we talk about regularly is that this is probably the single most reflective value, or single most data point that reflects our value of making sure we're meeting our community, making sure that we're getting access and being on demand and just seeing a high volume of patients. I know that gets used a lot of times in organizations punitively, and my heart breaks for that, because this conversation about productivity, like I said, it is the most value congruent conversation I ever have with people, is about the number of visits that you have within our community, and billable visits. We're not necessarily we're not counting meet and greets and whatnot. We're counting billable visits. Those are meaningful encounters that we're having with our community and our patients. So visits per day definitely is the number one thing that we look at. We look at handoffs as well, because we also, part of our main value is accessibility. So how easy it is for providers to access us and patients to access us. And if we want someone that's there that day, we want them to be able to have access, and we want to do a visit. We're not doing meet and greets. If it's a warm handoff, it's an encounter that included a contextual interview and some form of treatment and intervention that was done. And it's a clinical encounter.
I want to underline that, because you're not, I'm probably not unique, but it is not common for people to define a warm handoff as a relationship, a time that delivered some kind of value and delivered value that was able to be billed, that was documented and counts as value, as opposed to shook hands and said, nice to meet you, I'll see you on Tuesday.
Sandy, and I can hear it in your voice, and it's the same thing that for me, like, I get hyped about these conversations when we start talking about like meaningful encounters, meaningful moments with patients. And the thing that we tell our team, and again, we're behaviorists, so we're not going to reinforce something we don't want to see grow, is that we're not going to miss a moment. We're not going to miss an opportunity to have a meaningful connection with someone. And that's a handoff, right? And so a handoff is going to be something that is meaningful. It was intentional. It was purposeful. And for sure, was billable that we're going to do, because we also, and we'll get into this soon again about what we have to report as far as finances go, but that's even independent, I think, a little bit of this conversation.
I used to say to my trainees, or to everybody, add value today, because today is all you've got.
Oh, again,
and you may see this person again, but you may not. And so if they don't get some value now, why do they automatically think you're going to be useful to them?
And Sandy, think about that, like how profound that is, because the reality is that we'll probably only get to see them once. I mean, the majority of people we probably only will see once. And this isn't for PCBH or integrated care. That's for everybody that's a mental health provider. It's most likely you're going to see someone once. And like you said, though, just the relational frame, when someone's in the need, when someone's in the moment asking, and we're able to meet that need, that next time they need help, that next time that something's coming up, they're going to use us. They're going to come back to us, versus in juxtaposing that, what if we just come in and say, hey, how you doing? My name's Dr. Bauman. Schedule a follow-up with me. Might be a couple weeks before you can get in with me. If I'm that patient, I'm like, I'm not asking about this again. I'm not going to, why would I do that?
Yeah.
So visits, handoffs, provider satisfaction is a big one that we look at, and that's a big thing for us that we do every single year. And we have a specific survey that doesn't take long. As you know, PCPs, if they know someone's going to take longer than 5 minutes, they're not going to fill that survey out. So we're we have very intentional questions that we ask as far as like overall satisfaction. Are we helpful to your patients? Are we helpful to you? Are patients more adherent to treatment recommendations after seeing us? And then also just overall having a BHC makes my job easier. And it's a Likert type scale for all those questions. And then we give opportunities for people to give us, what are things that could be improved and what are things that they enjoy about it. And those are all qualitative responses. So that's a thing that we do every year. And it's a primary thing that we look at. The fourth thing is patient satisfaction or patient engagement data. And that's something that we do quarterly, that we get specific quantitative data on. And we get every single BHC every quarter gets 6 patient satisfaction or engagement responses, which then for the year is 24 responses. So a decent amount of patient engagement and information getting back to them. And then penetration rate, that paired with visits per clinic and handoffs, because the truth of the matter is, you could average seeing 10 visits a day and just see the same 40 people every single week, and your penetration's not that great. So pairing handoffs with visits and then overall penetration rate, meaning over the past year, what % of patients that's seen a medical provider have also seen a BHC, and that only is counted by having a meaningful visit or a meaningful encounter. That's another thing that we use. So those 5 data points are what we rest our kind of value on. Now, for sure, we track other things and we go over other things for sure. But those are the 5 metrics that for us as an organization, we have deemed is the best reflection of what our value are in being integrated care.
And so when you say we track other things, like what?
Yeah, so we track initial versus follow-up visits. So, we define an initial visit as something that is either with a brand new patient, a patient that hasn't seen a BHC in 6 months. So this is essentially a new episode of care, or a patient that has seen a BHC not sooner than 3 months, and maybe it's a different concern. So say Sandy, you see someone for smoking cessation, and 4 months later, I see them now for depression. We're assuming those are different episodes of care. We're going to deem that as an initial visit. So initial versus follow-up data points that we have.
Mhm.
We track scheduled visits, and we also track same day paired visits. So essentially that if I'm seeing a patient the same day as the medical provider, and it was already prearranged to be that way, we don't count that as a handoff because that's not what a handoff
Right.
is.
Yeah.
I mean, so we track that data, but the only awards that we give out during our award show are for handoffs,
Right.
number of visits, and those are the things that we're looking at. We also do track referral source, or not referral source, referral type. What are patients being referred for? And that's a thing that we always give feedback to our team on. And what we see is that about 55% of the reasons indicated for what the referral was for to the BHC is related to about, mental health related things, depression, anxiety, PTSD. About 25%, about a quarter, are related to behavioral health things, such as like relationship concerns, behavior concerns in kids, picky eating, things like that. And then another quarter, about 25%, is related to medical concerns, such as diabetes, obesity, hypertension, smoking, headaches. And so we do track that as well, and we give that feedback to the team. It just isn't one of the primary things that we're looking at
Do
specifically.
you count substance abuse as a mental health thing, or is that separately?
Yeah, that's a great question. So we put that in the behavioral concern. So we don't say it's necessary because within our template, we'll say the referral might be for alcohol use, or it might be for substance use. We're not sure when we're going into that room, or the provider isn't sure if this is a disorder yet, which then might transfer into this mental health related thing. We put that under behavioral health, which is, again, I think that could be an interesting thing. Like, should you put it on?
Yeah, I like that because it's about behavior change.
Correct.
That you're talking about.
Yeah. So we have that data as well. Obviously, we track a decent amount of, well, not a decent amount. I mean, we have financial data every month that we're going into, and we do share that with the team. The one thing that we always, we have very, at least in our BHC world, we have very, very value-driven BHCs. And we definitely have a lot of BHCs that, not that they don't care about finances, but it's just like, my value is patient care. So if I'm making money, if I'm not making money, that's irrelevant. Now, for us as directors, it's a super relevant thing for us, because for us to grow our program, the reality is we have to show that we're at least covering our costs, if not that we're revenue producing. So we get, data reports every single month that we track like hawks, Bridget and I, about expenses, incomes. Are we hitting budget as far as visits go? Are we getting paid what we thought we were going to get paid in different things? And the great thing is the past 3 years, we've been very successful in showing just the impact upwards to, and my CEO has given me permission to talk about this. But, we've shown upwards that after expenses, the BHC departments, which is a clinical and a training program one, have made the organization $1 million, so that's after expenses, that's after all these things. And if you take grants out of it, which I think largely we probably should, because when you have programs fundamentally built on grants, it's always just a lot of room for error that it is. If we take grants out, we're about $400,000 in the black after expenses. So again, very healthily, not only paying for ourselves, but then having a lot of opportunity for exploration.
Okay, very clear. So, but one of the things I want to underline, not undermine.
You can undermine, say it, go ahead.
Yeah, I can, is in some of the clinics that people are in the course are in, it is felt at top administrators feel that unless they set productivity goals, that they aren't really doing their job. That they set them for physicians or for PCPs, and so they're going to set them for behavioral health folks. And what the feedback from the behavioral health people, particularly the new ones who are right out of school, only been trained in specialty mental health, never in their born days did they ever see someone for less than an hour. that for those folks continually failing to meet the goals, supposedly, is an anxiety producing or alienating or both.
Mhm.
And that for people who clinically don't naturally now work in a certain way, and for a system that doesn't make it easy to work in a certain way, the feeling always is, I have to give this person less valuable care in order to meet my goals. And so it's not only not value driven, it's counter value. How do you help people with that? Because when you talk about it, it starts with value, it stays on value, it's all about our population, it's all about access for people, and we're keeping track, and we're making a living. But the focus on value is not universal by any means.
No, absolutely. And so a couple things my mind goes to right away. And I love what you said there at the end. Values are not universal by any means. So one of the things that we do very intentionally at the beginning, as soon as someone onboards, is that we spend a significant amount of time understanding their values and what it is. And we hope that actually even starts during the interview process, right? That we have an idea and understanding about what is this person valuing, because and this is the thing that, I think sometimes I wish we would rumble more about and be more, I feel like, what is it? Brene Brown's book, Dare to Lead, Clear is Kind. I think that is the one that's either that or Radical Candor, but I think it's Brene Brown, Clear is Kind. And I do think there is some sense where this might not be value congruent behavior for you, as far as really trying to reach a number of patients, providing a population-based health service similar to the medical profession. I mean, there's people that work in primary care and there's people that work in specialty care that might have longer visits. They get to focus in on specific things a little bit more. And that's okay. Both systems are needed. I think the difference and the trouble is, though, we don't like acknowledging that with people. It's like, hey, this might not be the most value congruent thing, and that's okay. That's totally okay. And then I think we start to, in my mind, beats me up a little bit because I don't know how popular this will be. Then we start like bending the rules for people, or we start bending things. It's like, well, we're not going to share productivity data, or we're not going to talk about this stuff in a lot of ways. And then my mind just, I've seen the ripple of that, and the ripple isn't in a positive way, because then you lose sight of what your focus is, drift happens, and all those different things. So I have a lot of grace for people, because a lot of times I don't know how often people know what they're signing up for when they get into integrated care. And so I think from the outset, during the interview process, and then definitely during onboarding, having a significant amount of portion dedicated to tell me what your value is. How can we make sure that you are meeting that value? So then my mind also goes towards, I think there's a really cool book called The Infinite Game, and it's one of Simon Sinek's books. And he talks about how a lot of organizations, we talk about finite goals, right? So productivity. You could very, very easily make that a finite goal by having a productivity expectation for us, it's seeing 8.4 visits per day is our productivity goal, right? If you just stop there, that is a finite goal. So what happens, say like today, this morning, I had a busy clinic, I saw 6 patients, I think it was 6 or 7, we'll say 6 visits this morning. I'm not in clinic in the afternoon, but say I was in clinic in the afternoon. What happens when I see my first 2 patients of the afternoon? Do I just get to say, hey, I hit my 8?
That's right.
I'm done, No, that's not the point of
that's
it, right?
crazy. You're right.
Yeah, and that's where, if it's a finite goal, though, that's what I think people start to think about. It's like, oh, the productivity expectations, 8 patients per day. As soon as I hit 8, I'm chilling in my office. I'm not taking any more handoffs. I'm not doing anything. It's like, no. Like, this is an infinite value. Our infinite value of high productivity to get to our community, to provide access to our patients and to our providers to us, that lives on indefinitely. we never hit that goal. So that's a big thing that we talk about, because we do have productivity expectations. And though we don't stop at it being finite, we say this is related to an infinite value. This is a reflection of our infinite value. And for sure, infinite values, we got to have a way of operationalizing them in a moment. And this is how we do that, is through a productivity expectation. But that's not the goal. That's never the goal. The number of handoffs is never the goal. It's what the number of handoffs represent, which is what our infinite value
yes. The difference between a goal and an indicator.
Exactly.
And the indicator says the system is too complex. Picking a goal, it will just simplify it, and it doesn't need that. But when it goes well, you'll see this happen.
Correct. Exactly. And I think we miss those things a lot, or we don't present it in that way. And I will also say, and Sandy, again, you have more experience to this, and I would love to actually know where your mind goes for it. I feel like in behavioral health, we get almost programmed a little bit more about being very adverse to anything like productivity goals, or adverse to anything that has numbers or metrics, and then about particularly sharing that with a group and all these different things. And my mind makes predictions about why that is for it. I will say, though, I think that's led us down a false assumption that you can't do that. And if someone would come to our monthly meeting, which again, we spend about 30 minutes every month with our award show, and we have fun. Yeah. We laugh, we tell jokes, we ask people what allowed you to do this, what values did you represent, and it's celebrated.
And you've detoxified data.
Correct.
You've said, we're talking to ourselves here, and we want to know more about how we're doing. Yes, if you only see it occasionally and only in the context of some kind of fixing of somebody, it feels toxic to people, and it feels anti-service. The choice is care about your patients or count them. And it turns out, if you work on a value of population health, those two go together. Let me ask you a different thing here.
Yeah.
Primary care behavioral health helps the practice in a number of ways. There have been studies that show that when the behavioral health person is there and responsive, able to be brought in anytime, that physicians see more patients. And so, and they're I don't know of a single place that captures that for the credit of the behavioral health. But it makes total sense that if I'm a doc and I've got somebody this is going to be a 45-minute conversation, I know it is, and I got somebody on the staff who not only has 45 minutes, but can do it better than me, does it all the time, then I'm going to see them, and now I'm going to see one or two more people in that 45 minutes. So, and that's a piece of how do you look at that? How do you, I guess, capture that for the purpose of talking to administrators and to yourselves and perhaps to people outside?
Yeah, I think it's a really great, and my mind always goes like, what are these indirect ways of almost like showing the value that behavioral health is going in? And you're absolutely right. I mean, there was that one study that showed in a pediatric clinic, right?
Yeah, Natasha Guj's study.
Yes,
Natasha
exactly.
and Jody.
Yeah, exactly. Which is really, really great and fantastic. And we have never looked at that. We never looked at that because it's an interesting thing of, almost trying to tell a PCP, hey, double book yourself on days that we have BHCs versus don't do it on days. Like sometimes it's a tough thing, but it's a brilliant idea. It's a really brilliant idea that I couldn't agree more with, that actually philosophically 100% my mind says is probably more right than or more often true than not true. I think this goes back to particularly directors on being very, very curious and inquisitive about how healthcare is funded, and particularly your people's systems are funded. And that's something that we had to do right from the beginning is, we sat down regularly with our, chief medical officer, then our chief financial officer, and just explain to us, how are we funded? How do we get funding? Outside of fee for service kind of opportunities, what other payments are we getting? What other opportunities are there to get? And what's interesting during those conversations is, one, you learn a lot. And then that translates into, thinking outside the box about how BHCs can be helpful to the bottom line. My mind will come back to the second thing that, what it also did was very subtly caused our CFO to engage in us, because he's like, our CFO just retired. He was a older individual. And I think he always looked at us as like, these kids and stuff. But I think what he said to himself is like, these kids are interested. Like, these kids are invested in wanting to make this a reality, like wanting to really help the healthcare system. So just, I think on a very basic level, asking questions and wanting to learn that process causes all those individuals to lean into us more, because they're like, they want to be part of this team. And I remember our chief medical officer, I've told this story before, talked to Bridget and I said, hey, what are your goals for the year? And we're like, hey, what are your goals? Like, we want them to be the same. And he talked about diabetes outcomes. He talked about hypertensive outcomes. He talked about wild child visits, and he talked about vaccinations. And we're like, hey, we're going to help. We're going to let our team know about that. We're going to let our team know that this is a way of us getting paid outside of fee for service, that if we can show that we're making impacts on these quality metrics, that we get more money from Medicaid and state programs. And we're still combing through the data, and my mind's always hesitant to make it like causational, like, yes, what we did see, BHCs had a profound impact initially on the data when we started to really look at that. And our CEO was like, I still remember he went on this talking tour about, because we got a significant amount of more money based on these value and quality metric related contracts. And he was like, one of the main reasons why we did, it seems like, is because of the BHCs. And that then I think started changing this conversation also with the providers seeing like, hey, getting the BHC involved not only helps with the finances, which is great, but providers, as you know, they're driven by what the outcomes. They're driven by like, hey, are you helping my patients? And getting that objective data to show like, hey, we're helping your patients. And it was done through this financial thing, definitely increased the amount of handoffs we were getting for diabetes and hypertension and all these other aspects. The other thing that we found was, patient engagement is a huge topic now, because that basically is, and I think we've had this conversation before. If there was one metric, it's patient engagement, because you can have the best intervention of all time. If no one does it, what difference does it make, right? That's right. So one of the things that we found was on days that patients saw a BHC, they rated their entire experience with the clinic, down from receptionists, pharmacists, providers, non-BHC related providers, but every aspect touch with the organization, patients rated higher on days that they saw a BHC versus when they did not. And when our leadership saw this, they were like, oh, this is what we're trying to get at right now. We're trying to get a patient experience that causes people to lean in and to engage more. And that then turns into people utilizing our clinics more, being more engaged with their care, which then leads to finances. I will also say real quick, Sandy, I will also say this though. I love when people talk about indirect things.
Yeah.
I'll be real. And again, you have a lot of experience. You have more experience than I do with this. Administrators, unless you can show a very, very clear causational relationships, administrators are going to be like, yeah, that sounds great. We really need this real direct thing. So it's not wrong. I don't think it's wrong to focus on these indirect, maybe cost savings, this indirect thing. The difficulty is that it's really tough to parse out, is this really due to the BHCs? We can make.
But what I want to, this is beautiful in the sense that there's a core set of data that you folks catch that is about you.
Yes.
And that you and your group and people up the line, everybody's got that. Nobody doubts that's the data about what you're doing. And then the data tells a story. And the data of, do people like their service on that day, correlates with their meeting a BHC. Is that proof? Hell no. But things don't run on proof. People don't make judgments on proof, much as we would like to think that we do, and we're all evidence-based. That's not how the world works. And if you show a bunch of PCPs that the proof is that when you guys get involved with a certain kind of patient, they're going to do better, that is not going to get you referrals. What's going to get you referrals is 2 or 3 stories about how the person with IBS was referred to you and what you did and what she said and how it made her feel better and how she said, I'm always going to, and that story, the person's going to say, oh, okay, I'll send you some more of those folks, because you guys do well with them.
Yeah, if I could comment on that real quick, obviously we also on the listserv, not only the quantitative data, we do love sharing these like qualitative like stories of PCBH. And you best believe, I would say probably once a month, Bridge and I, and even now other BHCs are doing it. We'll send emails to all of our C-suite with the stories, like you're saying. Like we just got our most recent patient satisfaction. You best believe we shared that with, and particularly the ones that were heart-wrenching, the ones that were saying, I was seeing this one that I even shared on the listserv. The patient said, I just lost my husband. This intern was kind. They saw me as a human. They were compassionate. You best believe we shared that with everybody. And I think that's another thing where the two things, one, as you said, like the stories are what sells. The data is great. The story is what I think really does sell. When you get those qualitative responses, and then also have a willingness, and I don't know, people might get upset at the beginning. I really don't care, but to share your wins, to share your stories, because especially with the C-suite, especially with everybody in the organization, sharing this, it's huge.
They need stories for when they go out.
That's what our CEO says all the time.
Yeah, like they're going out, they're talking to the Rotary Club or whatever, and they say we do good work. Well, the Rotary Club doesn't care.
Right.
But they tell a story that feels typical to people and say, oh my goodness, those people are doing really good work.
Damn right.
Absolutely. Let me ask a technical question. It sounds like every patient rates their experience every time they come. Is that true?
So
not to BHCs, but to visit, for a visit at the clinic.
That would be, so it goes back to that quarterly patient satisfaction data or patient engagement data, which would just be, it's not the majority of patients. This is our crosswords data that we ask out or we'll do calls after the visits to check in with them. So it's not every, I wish it was every patient. Now, the BHCs, we use a Duke Health profile measure for 12 and up that kind of is looking at quality of life scores, and we use the PSC 17 for 12 and under. Now, that's not they're essentially the perception of the visit, but I do think, and definitely would highly encourage, if people could come up with a very efficient way of asking each patient what their experience was, hell yeah, I think that is vital.
So what you do is your system does a sample.
Correct.
Okay. Yep. That's very clear. That's very clear. The other thing I want to lean in and underline is if your boss tells you something about data or something about billing or so forth, instead of saying yes, you say, I need to learn about this. I need to understand this. Who can teach me this? And it may take you 2 or 3 levels above your boss, but you're not going up there to complain or to talk above the boss. You're going up there because that's where you can learn. And so you seem determined to have a conversation with everybody who can teach you about this enterprise we call delivering primary medical care. And that when you go to see somebody and your agenda is to learn as opposed to talk them into doing what you want, the meetings go a lot better. And you get to say things like, man, that's really interesting. Or I can't believe you handle all this. you are so impressive, and all of those things that pay off for you later. Is that fair?
There's so many indirect and subtle ripples that happen when you just lean in and you approach things with curiosity and inquisitiveness. And I think that's where, and you're 100% right. And a quick story about it is that the thing that, and I'm sure a lot of BHC directors run into this, is that we kept being told, hey, BHCs lose money. It's nice that you're here, but you just lose money. And it's like, man, like that sucks. Like, and so like we were like, we really don't know anything about budgets though. Like we really don't know like all this different, like we get this P&L, like I don't know what it means. Like I don't know what each one of these things means. So we literally, and there was times that we had to prompt people multiple times, like our controller and our CFO and our billing and coding people. Like it's like, yo, what's going on here? And our billing and coding people were great because when we started to engage with them, they started to lean back and be like, well, what's going on? You guys aren't showing, this isn't the right code to use for this. And so that's why this is being denied right now. We're like, oh, well, can you tell us about codes that we do good with? Can you tell us about diagnosis and different things that like R codes and symptom-based codes that we still get reimbursed for? All these things, when we started to lean in, one, we got really great knowledge of being like, oh, okay, this isn't just someone trying to be a jerk and be like, hey, that doesn't, it's like, there's a lot of different things that play here that we had no idea about. And as you said, it caused those individuals to lean into us exponentially and really be invested in us and even seeing us succeed. Like we have people now, like our controller, who's like, you're all my favorite people, you know, because you're the only one. And she says this, she says, anytime that I send out the budgets and the P&L, the only people that respond back to me with questions or being like, yo, how about that budget is you all. It's no one else is looking at it. It's like, so that investment, it reinforces to them. It's like, hey, they're a part of this. They want to be here.
That's great. I love it. Anything more you want to tell me? I feel like I don't want to let my crowd down and not ask the important stuff, but I could get almost all the important stuff out of what you already said. So if you had this group here of they're all in your position, essentially, they're running behavioral health in a big or small organization, but they're all managing and they're all new at it in the sense that for however many years they've been in it, nobody went to management school. Nobody has an MBA.
Right.
Nobody, I think almost nobody, I think nobody has any kind of formal mentoring in the role. They were just either the first clinician or the best clinician or both. And now they're the head clinician in a program and they're trying to say, oh, I'm a manager? What is that? And so that's why we do the course. That's why I do the course.
Hell yeah.
But also,
that's where
it means that if they were here, what else would you tell them?
Well, the first thing I would say is that, Sandy, and what you just said is not only true for like the behavioral health directors, but it's true for like all medical directors as well, right? It's like you get these people like they're just the best clinicians, or maybe they just applied for the job or something like that. But like it's a lot of times it's not like people that have like these really sound things. And I think that's where we've taken on ourselves, particularly whether it be with like the finances and the data part, but even more of like leadership skills and stuff. We've approached that the same way we did being a BHC. It's like, I got to read, I got to get mentorship, I got to take a class with Sandy Blount. Like I got to do these things to develop these skills, because the same amount of work that it took in the number of years I had to go to grad school to become what I think is a good BHC, I got to still do that to develop these leadership skills, these finances knowledge, all that different stuff. I think if there was overarching thing, I would say is that, one, be kind, I think, to yourself, because this stuff, as we've always talked about, like when you go to conferences, usually, and even presentations and publications, everybody always talks about the good things. Everybody always talks about the successes and the things that came out that were really amazing. It gets everybody hyped and pumped up and stuff like that. Look, I wish that was most days. And most days, and especially at the beginning, aren't like that. There's a lot of rumbling. There's a lot of difficulties. There's a lot of banging your head against the wall and just like, are we still having this conversation? What are we talking about right now? And I think recognizing that and having that kindness for yourself, because that's going to allow you to keep leaning in, that constant reminder, we're all on the cutting edge and we're going to get cut. I mean, that's the point of being on the cutting edge. Like, it's going to be really difficult. It's going to be really hard, and that's okay. It's not a bad thing, but we got to keep leaning in to it. And I think the two last things my mind says is, one, don't shy away from data, and creating a context with your teams that, you're not shying away from this. Like, this is a conversation that we're going to have, leading with the why, leading with the value of why we're doing this, what data, we track this data. It's not just to track this data because we're just doing it for the hell of it. Like, we woke up one day, it's like, oh, let's track patient visits. We're not going to talk about why we're tracking patient visits, or we're tracking handoffs. Like, why are we tracking handoffs? Why is that important? So making sure that, we're not shying away from data. Data, as you said, and I loved how you said it, data can tell a compelling story. And that oftentimes can really drive just innovation and drive successes. And then the last thing I think, which goes along with that, is that create a context with your team that you're going to rumble. We're going to have a context where we're going to be candid. We're going to have a context where discontent is allowed to be voiced, and we can talk about these different things, and that's okay. And we can still go. I always, I've read a number of books on leadership, and I always think about, Google and Apple, not endorsing those companies, but Google and Apple, they talk about these debates that the C-suite will get into. They talk about these conference rooms that will have people, arguing with each other, but it's still out of love. It's still out of like engagement. Like, people aren't, holding grudges afterwards. And the only way that's done is that if people know that people care about themselves and that we're all in a very mission-driven, purposeful environment. And when we get that, now we can have rumbling. Now we can have a context of candor and being candid with people. And I think that's a very important thing and I had to do this last month. I had to talk to BHC about, hey, we're seeing some numbers here. What's going on? And we rumbled about it. And it was great. It was great because I got to learn about them. They got to learn where I was coming from. Having that context of it's okay to rumble, which is usually a context of love, of kindness, and of compassion that allows that to happen.
Because you're always going to find out something that makes them make so much more sense.
100%.
Once you have that conversation. And,
absolutely.
Yeah. Well, David, I just can't thank you enough.
I appreciate this. I love talking to you.
Okay. So I will stop here. I will send you a link to the video. We'll watch it. People, I don't know, you may get some thank you notes from this class as well. I don't know. But keep doing the great work, man. And
I appreciate it, Sandy. Thank you so much for everything you've done, man, and continue to do.
All right. Talk to you later. Bye.
All right, man.